Good afternoon, everyone. Oh, come on. What an anemic response. Good afternoon, everybody. It's not easy going up after lunch, so I'm going to try and keep you entertained a little. So this morning we spent a lot of time talking about more global, high-level care. We're going to bring it back to the provider and patient perspective. So that's what this session's about. And I want to thank Samilia for sharing her story earlier today. And I'm going to add to it a couple of additional patient stories. So I'm Barbara Barnett. I am from the class of 13. Go 13s. Yeah! Sorry, I do that every year. I can't resist. I'm the Chief Medical Officer of Mount Sinai Downtown in New York City. Has anyone ever gone to New York City in the room? So Mount Sinai Downtown is south of 34th Street, river to river. It includes 600 patient practices. We have a comprehensive women's cancer center at Chelsea. It's in the Google building on the west side. Then if you migrate over to New York Eye and Ear Infirmary, we have Mount Sinai Beth Israel, and we have the largest multidisciplinary ambulatory site. So that's Mount Sinai Downtown. So one of the nice things about a chief medical officer is often you get really complimentary and very nicely written letters from your patients about the care they received. But then you get some that are a little hard to read. And I'm going to share some of those letters. These are actual letters that we received at my hospital and some of the patient concerns that they've raised. So we all know that I'm preaching to the choir. Healthcare is a right. It's not a privilege. And all people need and deserve access to comprehensive, culturally sensitive, competent healthcare. To improve healthcare outcomes, we need to break down the barriers that keep healthcare out of the reach of so many who come from diverse backgrounds. Barriers like discrimination based on race, gender, and socioeconomic status. Today we'll highlight 3 patient stories, one on race, gender, and one on socioeconomic status, to highlight some of the challenges our patients face. Deepu will follow, and he will share some of the biases providers experience from their patients. So what does it matter? Right? It's wrong. We all know it's wrong from a social justice perspective. And these disparities that these patients are facing not only impact them, but they impact the overall improvements in the quality of healthcare for the broader population. In one study, it costs $93 billion in extra unnecessary medical costs, and $42 billion in lost productivity per year. Now, I went to Tufts School, so I can do this. It's $135 billion in a year of unnecessary costs. And to be quite honest, the American population is becoming more and more diverse. So this is Mount Sinai Beth Israel. This is 16th Street, right in front of 2nd Avenue. Stuyvesant Park is there. It's the epicenter for opioid abuse, homelessness. And it was founded in the 20th century. It's a sanctuary hospital initially founded for immigrant Jews living in the tenements of the Lower East Side. I didn't realize this when you first came to the country. You weren't allowed health care for the first year you were here in any of the city and federal buildings. So this hospital really started with a mission and continues with that mission even today. We serve a diverse population from Manhattan's Lower East Side, Chinatown, Gramercy, West Village, and Brooklyn. So we have a very, very diverse population. Almost every language is spoken in our hospital. And I was here before you 2 years ago talking about LGBTQ community that we serve, and we've served well for decades. We're also a site for a comprehensive transgender medicine and surgery program the team presented 2 years ago. We're happy to say we're 3 years into the program. We've done 2,000 trans surgery. We're probably the largest internationally. All of our employees have been trained to provide culturally sensitive trans care. So we consider ourselves to be a center of excellence in that area. Our staff is equally diverse. So our patients are diverse, and our staff kind of mirrors our patient population, speaking multiple languages. So when I read some of the letters, it's even going to be harder for you to understand why some of these things are happening. So sickle cell disease, just to give for those of you who are non-clinicians in the room, it's the most common genetic blood disorder in the United States. 70 to 100,000 Americans are affected. 1 out of 500 African American children are born with sickle cell anemia. 2 million have the trait. And unfortunately, life expectancy is probably they survive to the 50s. Natalie's the patient. I'm going to tell you her story. I first met Natalie. She was in her final year of college. She was 4 credits shy of graduating, but she couldn't seem to finish those last 4 credits because she had multiple hospitalizations. The one interesting thing about sickle cell anemia, again, you saw how common this disorder is. Last I counted, in this country, there are only 7 comprehensive sickle cell centers. Just to give you a comparison, cystic fibrosis affects a minority of patients, generally Caucasian, of Jewish background. There are over 150 cystic fibrosis centers. So most of the time when patients get into trouble, they come to the hospital because they're having a pain crisis. So you see that sickle cell on the end? It doesn't carry enough oxygen to the tissues and bones, and it causes death of the bone and tissue. And that's very painful for their patients. So just to give you some context, at the hospital at that time, we had a 1 milligram diluted aliquot rule. You can only give a milligram at a time. Natalie comes to us. She's on 4 milligrams of Ativan, diluted, 4 milligrams of diluted every 4 hours. But we're only going to give her a milligram of diluted every hour or so. So this is her story. When I got admitted, my pain went from a 9 to 20. The more they play around with giving us meds, the longer our stay will be. Sometimes I feel that the doctors are not on our side. Sometimes it takes a while before I go to the ER because I know I'm not going to be cared for the way I should. As a patient, I know what works and what doesn't. If they paid more attention to me, then I would probably be home by now. This is the part that really hurts. Often I feel that if I had cancer, I would be better off, and I would not be looked upon as a drug addict. Only thing I'm addicted to is working to feel as a normal human, pain-free, and healthy woman. Natalie is an incredibly bright, articulate woman who sat on a performance improvement team with me, met every week for 3 years trying to improve the care we give for our sickle cell patients. But it's really upsetting in a place like New York City, where we're so diverse that patients experience this from their physicians. So for those of you, gender dysphoria, that's a medical condition in which there's a conflict between a person's physical or assigned gender and the gender with which he, she, they identify. These patients are at increased risk for stress, they're isolated, they have a lot of anxiety, very poor self-esteem, they're prone to suicide. In one study, 41% had made a suicide attempt. If you compare it to the population, it's 1.6%. And you remember, I just told you, we are experts in trans care, right? Every employee has gone through cultural sensitivity training, if not once, twice, or 3 times. Some of our staff are trans patients. And this is a letter we received from Aaron's therapist. Aaron is a trans male. He heard 2 nurses talking about him and using feminine pronouns. They were laughing. He shared that it went on for a while until finally another nurse corrected them, saying he. We can't get the pronoun right. I can't tell you how many times this is a complaint. We can't get the preferred name right. After they were corrected, the nurse mocked him every time they said he. He said that if the health professionals treat me this way, how can I expect anyone else to treat me differently? As his therapist, Aaron has been deeply impacted by the events that happened at your hospital. I am particularly disturbed because your hospital advertises that you're a leader in LGBTQ care. So, the homeless. I always thought San Francisco had more homeless than New York City for some reason, but we rank the highest in homeless, 76,000 homeless patients. But most of our homeless are in shelter. We don't have a lot of street homeless, but we have a lot of homeless in shelters. Homelessness is a part of the fabric of our community. These are our patients. They live in our community. We know many of them. The park I showed you, a lot of them live there. They live on First Avenue. But I'm going to share with you a comment made on Yelp from not one of our homeless patients, but from one of our other patients about our homeless patient. Explain why this hospital allows homeless to come in and squat in the orange pod, that's in our emergency department, and can get a tray of hot food. The transient named Yolanda, who we all love, wanted food, and the aide actually brought her a tray. Okay, Yolanda, I'll get you a hot tray. And guess what? Another transient comes in and sits next to Yolanda because they know each other. They were stinking up the whole area. Employees here know her by name like she's a regular. She eats and blasts music from her phone, and soon enough this guy, apparently named Taylor, falls asleep in the chair next to her. I am all for helping the needy, but they can't just come into the hospital for food, shelter, and Wi-Fi. If this hospital doesn't shape up, be sure to see and smell Yolanda and Company when you visit this hospital. My ED colleagues are here. I can't tell you how many of our colleagues were upset by this Yelp posting. And this is in a community that's culturally diverse, that has done a lot of training and education, and yet we still have such disparity in care. So that's 3 patient stories. For every 1 patient story I pick, there's probably 1,000 others that make it to pen or paper. And, you know, we struggle with this, and I personally struggle with this. How do we change this? And how could these patients have great outcomes if this is what they experience when they come to a hospital that's supposedly sensitive to take care of their needs? So with that, I'd like to have Deepu share the provider perspective.
Thank you, Barbara. How can I follow those stories that she said? While Anno is bringing my slides up, I'll tell you, I'm Deepu Ushakumari, one of the anesthesiologists. I work in Charlotte, North Carolina now. Used to work in Maine, have worked in Philadelphia, worked in Cleveland. So my stories are from across the spectrum of the country. One of the first things that when you search for provider disparity or patient disparity, what they claim is physician-provider concordance. So then, of course, I looked at Wikipedia, looked at what the meaning of concordance is. It's a state of harmony, a harmony between patient and physician, or patient and provider, just that makes sure that they get the best care they want. This concordance can be based out of all those things Barbara mentioned: gender, race, sexual preferences, language, and how often do we get it? She explained to you some stories about patients not getting it. I'll explain to you. So most of these things were my own experiences. So first year in, I think the first one is from Philadelphia. If you walk in to take care of a patient, and I was asked, oh, can I have a real doctor take care of me? The story continued on to like, okay, I want to know what do you mean by a real doctor? Like, oh, you don't look like a real doctor. Okay, fine, I have a stethoscope, I have a badge, everything which says that I'm a doctor. And keep in mind, I'm a board-certified anesthesiologist from India, where doctors are treated with respect. They revere you, they bring you gifts. And this is what I experienced. And then another story, the second one is from Maine. I mean, no disrespect, but I don't want to be treated by people of your kind. It's those little words that you face as a provider every day. You brush it off and you move on, but sometimes it hits. So some people are funny, or they try to be funny. This is often compared to the person named Raj in Big Bang Theory, and saying that you sound like him. Do you have to drink alcohol to have to speak to women? Is it funny? Yeah, I laugh at them because I can see the humor in it. Or the worst is, since the slides were made, I made these slides about a month back, I think, Molly, and I sent it to her. I had another experience. Actually, this is quite funny. In Charlotte, when I walk into a patient's room and he's there, I'm talking to them about cardiac anesthesia. I do anesthesia for heart surgeries, and I'm explaining to them bypass machine, all those things. Nothing is entering him. I can see this glazed over look, and then he says, I'm also Indian. I'm like, okay. And she goes, but Indian with the feather kind, not the dot kind. I found that funny. I laughed at it. It was just fun. So that's one experience since I made those slides. So it didn't make it into those. Another experience last week, or this week actually, was walk into a patient's room. Patient is Indian, obviously. The family is Indian. There's Indian of my kind, the dot kind, and sitting there, and the nurse in the room asked me, "Oh, doctor, do you speak Indian, their language?" I'm like, "What do you mean by Indian language? A country which speaks 23 official languages, more than 200 dialects. What do you mean Indian language?" And the family is like flabbergasted that the nurse asked that question. And then they start speaking to me in Hindi, and I understand Hindi. So that helped me make a connection with them. So, and yeah, the ever-present bias of having a brown skin and expecting to be good at computers. So, then some overt xenophobia. This is actually one of those things that made my cultural shock into acculturation in this country really bad, was this experience in which I was told, we do not want people from the jungle here. Things are different in the civilized world. That has happened only once. The funny comments are more common. So this is a rare event. So of course I look back, and being a nerd, I look back into literature and see what other people have said. And this is an experience of a physician at Hershey. Someone pushed him against a wall and said, "Where did you park your camel?" So it's not rare. And how common is it even in pediatric patients? Experience of a Spanish-speaking physician. I don't want some spick doctor, I want the other lady. This was said by a 6-year-old. And you can see, like, the story goes on, and saying that the father who's in the room acknowledges it. So now this happened to someone else. Now again, this is not my story. The janitor was so smart, he's telling everybody what to do. It's these hidden assumptions. These are all mine. These are subtle in terms of, do you speak English? How old are you? These are innumerable, so I don't really, not a story in there, but these comments that you hear. So what does employers or hospitals have? They have a right to provide a workplace free of discrimination. It's Title VII of Civil Rights Act. So if they violate it, or if the hospital tells the physician or a provider to go take care of somebody, they are violating that act when they are not comfortable taking care of it. There has been cases in which hospitals has been sued, and unfortunately or fortunately, there's not many in which providers or physicians have sued the hospital, primarily because we all hold a moral, ethical responsibility to take care of the people. So look at what surveys were there to document this across the nation. This is a combined survey by WebMD and Medscape. About 2,000 physicians were involved. Really weighted survey in which they used this AmeriSpeak panel, which is supposed to reflect the diversity in the country. And as you can see, the most common bias reported by physicians, this is all reported by physicians, is based on age. And second is ethnicity. And one of the most common reasons why patients request a different provider cited in this survey is having an accent. And unfortunately, I have one. So what happens when a patient requests a different provider based on their beliefs or their preferences? More often than not, they are referred to another physician or another hospital. Then sometimes they do accept the treatment from the physician. So yeah. What impact did it have on the clinical care? This shows that we are providing great clinical care in spite of all those. We there is virtually a very minimal impact on their clinical care from these events. There is this, I'm not sure whether you can see that writing in there. They came up with an algorithm in the New England Journal of Medicine in 2016, how to deal with this. I'll go through it. First, you assess them medically. Are they clinically unstable? If they are, treat them no matter what. If they are stable, then look at why they are making this absurd comments. Is it because of their decision-making capacity? Are they delirious? Are they in withdrawal? Then if they have decision-making capacity, if they do not have decision-making capacity, you still treat them. If they have decision-making capacity, talk to them. Find out why they have a reason for their request to be switched providers. Is it pure bigotry? And then if it is, discuss the options. See where you can find a common place. And if it is possible to continue to take care of the patient, do so. And as she mentioned, there is no formal reporting structure or a policy in many of the hospitals that I've worked at. And do people get training to address such behavior? And are our supervisors aware of what to do when somebody reports such a comment? And this is what happened according to the same survey. More often than not, the care was transferred to another physician. Or sometimes they ask the patient to leave the practice and go somewhere else if it's an outpatient service. But surprisingly, 20% of the physicians were asked by administration to continue to take care of the patient. That's surprising. So these microaggressions in a training perspective, it's worse when you are a trainee than a physician. And when you are fresh out of medical school, go into residency, you will tend to make it your own. You think it's your fault that they are behaving that way. So then you see a high rate of attrition of minorities from medical education. They leave because they can't tolerate such behavior. Then who suffers? The healthcare suffers, because she just mentioned our population is getting more and more diverse. What if our healthcare providers are not getting diverse? So that's what we can do from an institution standpoint. What can a person do, all the clinicians in the room? If you are subjected to such comments, you ignore them, you focus on the shared goals, try to depersonalize the event, and foster a culture of support inside the hospital. Lean on others, I think. That would help. And Scott had mentioned MLK earlier, 51 years, right, today. Brilliantly stated. People fail to get along with each other because they fear each other. They fear each other because they don't know each other. And they don't know each other because they have not communicated with each other. That's it. I don't have any more literature to say, but I just think the stories are more valuable than literature. Thank you.